Good evening, everyone. I think we'll get started. There may be people just continuing to wander in. Welcome back or welcome to the Canadian Concussion Center's webinar series, which is sponsored by LiUNA, the Laborers International Union of North America. I'm Leslie Rattan and really pleased to be moderating our series that was developed for individuals that have sustained concussion. And we certainly welcome family, friends, and healthcare providers as well. The sessions, you may know, are recurring every other week on Tuesday evenings from 6 to 7. And just for your information, all of our webinars are recorded and you can find those on the Canadian Concussion Center website. Christian will be putting the link into the chat. So if you've been here before, you'll know in terms of the format, begins with a speaker, expert speaker on a topic for about half of our session, and then we end with a question and answer period. You will see at the bottom of your screen, there's a chat. So if you're having any issues, technical difficulties, please reach out there. If during the presentation or afterwards you have questions, please answer those or enter those into the Q&A area there. I see a question, I think, in the chat. You'll see that we have the 10th annual Concussion Research Symposium is being held by the Canadian Concussion Center, and that runs on April the 21st. So this is definitely more directed more at researchers, healthcare providers, and the registration is there. But we also have a concussion public forum that happens the evening below, which is Thursday, April 20th. And Christian is going to be putting the link where you can actually register. The public forum is free. You just have to register. And it's available both. There's going to be an in-person and a virtual option, so you can choose from those. So just before we get started, we're just going to run a quick poll, as we always do, just to find out who's in our audience. So if I can just get Christian to put that up, and I'll just give you a couple seconds to fill that out. Great. So this evening, I'm really pleased to welcome back Dr. Abe Snaiderman, who was with us a few weeks ago, and he's going to be presenting again on drugs for neuropsychiatric symptoms of concussion. Dr. Snaiderman is an assistant professor in both the Department of Psychiatry and the Department of Medicine at the University of Toronto. He's the founding director of the Neuropsychiatry Clinic at the University Health Network at Toronto Rehabilitation Institute, Brain and Spinal Cord Program, where he has worked for the past 25 years. He's been involved in the field of physical and neurological trauma for many years. As a clinician teacher, he's been involved in training medical students, residents, fellows, and ancillary health professionals, as well as the general public, for over 25 years. He's a member of the exam board and an examiner in psychiatry for the Royal College of Physicians and Surgeons of Canada, and winner of the Ivan Silver Award for Excellence in Mental Health Education, given by the University of Toronto. He is also a member of the board of directors and advisory board of several acquired brain injury organizations, initiatives, and programs. So with that, I'm going to turn it over to Dr. Snaiderman.
Thank you, Leslie, for the kind, as always, introduction. And welcome everybody back to this torture session. If you were in the previous one and you're back, thank you for your courage. And I'm going to start sharing my screen. Please let me know if there's any glitches. If you cannot see the screen, can you see, Leslie, can you see the cursor?
Yes, it looks good.
Awesome, thank you. So we're going to be talking today about drugs for neuropsychiatric symptoms of concussions. If you were present in the previous one, I talked about the neuropsychiatric aspects and symptoms of concussion. And this time we'll move a little bit forward towards treatment. So disclosure, as always, being part of the university, we have to disclose whether we have any conflict of interest, particularly since I will be discussing medications. And I have no conflict of interest. I have no affiliation with pharmaceutical industry. I will discuss off-label use of medications, which means that some of the medications I will talk about have other uses than the ones that have been approved for or developed for. As before, I am a clinician teacher, not a researcher. And again, no research will be harmed in the making of this presentation. And I have 30 minutes, which is not enough time. But anyway, a quick reminder, if you saw my previous presentation, that mind in our world equals brain, and brain equals mind. There's no such thing as organic versus psychological. It's all the same organ. So we talk about neuropsychiatric problems after mild traumatic brain injury. And also I'm going to be referring to concussion as mild traumatic brain injury. They're interchangeable. So we talked about depression, anxiety, sleep disruption, memory, energy issues, substance use, and many, many others. For the sake of time, though, we're going to concentrate on depression, anxiety, and sleep, because if I were to talk about all the other issues, they will kick me out of the speakers panel for taking too long. So in the symptom continuum, what does that mean? Many illnesses share symptoms and signs. A symptom is something the patient presents with and is able to express themselves. A sign is something the physician observes, or not just a physician, any healthcare provider observes. So what are the symptoms? So for example, worry, anxiety, muscle tension, palpitations, sweating, dry mouth, nausea, all those are very common. And on the other end of the continuum, depression, anhedonia, lack of seeking of pleasure, appetite disturbances, feelings of worthlessness, suicidal ideation. But in the middle, sleep disturbance, psychomotor agitation, forget about the psychomotor, just stay with agitation, and difficulty concentrating, as well as irritability and fatigue, are shared by these two entities. And I'm going to assume that there are members in the audience that are not medical staff or healthcare providers. So this is what we're going, that's why I'm going to such length in explaining some of these things. So diagnosis continuum, we have symptom continuum, now diagnosis continuum. So we have major depressive disorder on one end and generalized anxiety disorder on the other end. But more often than not, patients don't read the medical books and present with both. And we have to be cautious and aware of that. So then we move on to treatment continuum. Not surprisingly, when you treat anxiety, you might also be treating depression and vice versa. And the same medications that treat depression might or will treat anxiety. So the name antidepressants is correct, but it's kind of losing its meaning because these medications are being used for a whole bunch of other things, including non-psychiatric, non-mental health issues. So before we proceed to the medications themselves, I want to give you a bit of a reminder of how our brain works. And for that, we're going to show you a video, which I hope will work. Can you hear me? Can you hear the music?
Yes, we can.
Thank you, Christian.
A child's experiences during the earliest years of life have a lasting impact on the architecture of the developing brain. Genes provide the basic blueprint, but experiences shape the process that determines whether a child's brain will provide a strong or weak foundation for all future learning, behavior, and health. During this important period of brain development, billions of brain cells called neurons send electrical signals to communicate with each other. These connections form circuits that become the basic foundation of brain architecture. Circuits and connections proliferate at a rapid pace and are reinforced through repeated use. Our experiences and environment dictate which circuits and connections get more use. Connections that are used more grow stronger and more permanent. Meanwhile, connections that are used less fade away through a normal process called pruning. Well-used circuits create lightning-fast pathways for neural signals to travel across regions of the brain. Simple circuits form first, providing a foundation for more complex circuits to build on later. Through this process, neurons form strong circuits and connections for emotions, motor skills, behavioral control, logic, language, and memory during the early critical period of development. With repeated use, these circuits become more efficient and connect to other areas of the brain more rapidly. While they originate in specific areas of the brain, the circuits are interconnected. You can't have one type of skill without the others to support it. Like building a house, everything is connected, and what comes first forms a foundation for all that comes later.
I love that video. The graphics are fantastic. So as you can see, when we think of the brain as a computer, it's actually wrong. The brain is more like a super network of 100 billion neurons with trillions of connections. Those connections we call synapses. And if you see to the top right of this graphic, you see one neuron connecting to the other in the synapse. Now, this is a 3D scanning microscopic image of two neurons that are kind of hugging each other. You might call it 50 shades of gray matter. Bad joke. And you can see that synaptic, you see the body of the neuron, the axon, the other axon, and how they are connecting. Now, in that connection, sorry about that, in that connection, which we call synapse, this type of mechanism, which is very, very strangely simple, our brains, our connections function like a lock and a key. And I'm going to explain how. So we go back to the neuron, the synaptic. So I'm going to show you a cartoon of an amplified synaptic left here. So this is one neuron, this is another neuron and a third neuron. So these vesicles in the inner of the cell, this is the membrane, the covering of the neuron. So these vessels are formed way up in the body of the neuron and transport themselves through tubules to the end of the synaptic membrane, where the vesicle connects, fuses with the membrane, releases the neurotransmitter, which could be in this case a dopamine, or through intake through your mouth or your IV or IM, an opiate, for example. So the opiate receptor looks very different than the dopamine receptor. So when this receptor flows through the synaptic cleft and lands on this receptor, only this receptor can accept this particular molecule. It basically opens a channel in which other substances, could be calcium, could be other things, flow into the body of the postsynaptic neuron, the neuron after the synapses, and enhances the transmission of an electrical stimulus. And that's how it works. It's relatively simple concept without extremely complicated process. Now, what happens when dopamine reaches the presynaptic neuron membrane, fuses with it, releases dopamine, dopamine floats and pop, drops into the receptors, the presynaptic and the postsynaptic receptor, and then floats back up. And then this guy, which is the uptake receptor, the uptake mechanism, so to speak, catches dopamine and literally brings it back into the presynaptic membrane to be recycled. So basically, the body is constantly recycling neurotransmitters, which could be dopamine, serotonin, noradrenaline, etc. So the way antidepressants work is rather ingenious. So we need to increase the level of these neurotransmitters in this area. So either we make the cell produce more, which had a lot of side effects, or we take more, like in Parkinson's disease, dopamine, or we recycle. And how are you going to recycle? Well, if you don't recycle, if you block like a key, you turn the key and you block the reuptake, this molecule of dopamine cannot go back in to be recycled. So it stays in the synaptic cleft in the space and continues stimulating the next neuron, hence improving neurotransmission. Now, neurotransmitters can be many, many types. With vitamins 3, small molecules, tiny molecules, neuropeptides, and gases. I'm not going to go through this, just focus on the arrows: dopamine or epinephrine, which is adrenaline, serotonin, melatonin, which is one of the sleep hormones, and other substances. I'm not going to spend too much time. So there's there's literally hundreds, if not thousands, of neurotransmitters. Where are these neurotransmitters produced? In the center of the brain. So if you saw my previous presentation, you're familiar with this slide. In the center of the brain, we have what's called monoaminergic nuclei, where these neurotransmitters are manufactured. Literally, this is where they're made. And from there, from the center of the brain, they're transmitted upstream through the pontine basal cortical relays and distributed to the rest of the brain. So you can imagine a concussion, a mild traumatic brain injury will disrupt all of these processes, as I said in my last presentation. So what are antidepressants? First of all, it's a group of medications or interventions associated with a decrease in symptoms and signs of depression. This is one of those Snaiderman, of course. But the non-medication interventions, such as exercise, psychotherapy of various types, meditation, social contact, which is why during COVID, this was such a problematic era, so to speak, for patients with mental illness. Electroconvulsive therapy, transcranial magnetic stimulation, and in patients with seasonal affective disorder, light therapy are also antidepressants. Now, in the medications, we have the old ones from the 1950s, 60s, and 70s. And the more legacy I become, the less old these dates start to look. And then the new-ish, which is 1980s and on. And lastly, the next classification is what type of neurotransmitter. So let me go through these types very quickly. This is a really busy slide, something I tell my residents never to do, and here I am doing it, but we'll go very quickly. The first antidepressants were invented in the 1950s, and they were the monoamine oxidase inhibitors, MAOI, so MAOs. These were fantastic medications who were game changers in depression, provided you don't eat certain foods or drink wine, because then you die. They would develop hypertensive crisis if they mix with certain foods that can be lethal, and many people died. So they fell out of favor. The next are the tricyclics. And of this, I want you to pay attention to this guy. This is the mothership, imipramine. This was the first of the tricyclic antidepressants developed in the late 50s, early 60s that proved extremely efficacious. And to this day, it's the gold standard. So every new antidepressant is compared in efficacy to imipramine. Now, what are the problems with this family of medications? They're really effective, but have really hard to tolerate side effects like weight gain, sedation, dizziness, blurred vision, horrible constipation, dry mouth, and at higher doses, they can be toxic to the heart. So again, not ideal. The next stage would be tetracyclics. Now, if you see why they're called tricyclics, because there's 1, 2, 3 benzene cycles. And in tetracyclics, 1, 2, 3, 4. And these compounds, one of which is still in the market, bupropion or Wellbutrin, became very popular. However, bupropion started to have some side effects that people didn't like and fell off the market for some time. Then the next family of medications were medications like trazodone, which many patients are using for sleep, and this one, which was not available in Canada. But again, side effects were not fantastic. Finally, in the early 1990s, they hit the jackpot, which is the SSRI, selective serotonin reuptake inhibitors. And now you know why reuptake and why inhibitors. Those guys block the receptor that brought in the molecule of serotonin to be recycled. So they block the reuptake, and they're selective because they only act on serotonin. These other guys act on many other neurotransmitters. This one is mostly serotonin. Typical examples: fluoxetine, sertraline, citalopram, paroxetine, fluvoxamine, citalopram, etc. Incredibly well tolerated, incredibly safe. Overdoses with SSRIs are rarely lethal. and remain one of the safest, more efficacious medications ever invented. And lastly, newer medications starting coming to the market, like venlafaxine and desvenlafaxine, as well as others. So which one is best? Ladies and gentlemen, and the Oscar for the best antidepressant goes to, drum roll, I should have put a drum roll clip. Imipramine, it's still the best. Unfortunately, imipramine could not be here to receive the award due to the rather difficult to tolerate side effect profile, but in imipramine's absence, her daughters, the cipramine, clomipramine, and amitriptyline, wait a second, same side effect profiles. So there's many types and names of antidepressants. These ones are the ones most commonly used: citalopram, paroxetine, fluoxetine, sertraline, duloxetine, venlafaxine, desvenlafaxine, mirtazapine, and bupropion. We still don't have one antidepressant that's the best, well tolerated, no side effects, as efficacious as imipramine. The fact that you see so many names means that we still don't have one. So the best results are achieved when we use medication, but also psychotherapy. And this has been studied to death. If you just prescribe an antidepressant and you don't have a psychotherapeutic arm to the treatment, there aren't as good results. So using antidepressants after brain injury. I'm going to give you my experience. My first chore is, what is the diagnosis? Am I dealing with somebody that has post-concussive syndrome or depression, anxiety disorders? Is the patient delirious? Is the patient demented? Or are there any other medical conditions like thyroid, diabetes, renal problems, liver problems, hematological problems, anemia, etc. So that's my first role. Before a psychiatrist, before a neuropsychiatrist, I'm a physician. And I have to rule out that there aren't any other things that could mimic the presentation. Then are there other diagnoses within my field of practice, such as sleep problems, pain, or other medical issues, as I said. And then comes the what I call my right-wing approach, and I'm not right-wing. The right-wing medication for the right diagnosis at the right dose, in the right patient, at the right time, and for the right duration. Sounds easy? It ain't. We have to consider personal factors. What is the age? Younger and older populations tend to be more sensitive to side effects. Gender. It's very strange and maddening that a lot of the research is done in males, and we do not know as much the responses in females. Only recently, in the past 10 years, have we started to realize that this is a problem. Level of education, social financial situation, is the patient involved in litigation, past medical history of mental illness. What are the patient's personal preference? The patient might have tried one antidepressant and hated it, and might be willing to try something else. Past experience and exposure to antidepressants and family history. If the mother or the father responded to, say, sertraline, chances are the daughter or son might do too. Cost is an issue. We would think that in Canada is not such an issue like in the States, and the prices in the States are outrageous, but the prices in Canada are outrageous too. Having been to Europe, I couldn't believe that I bought a full box of acetaminophen for €1. I thought the pharmacist was pulling my leg because I was a tourist, and she looked at me like I came from another planet. So which one? In mild TBI concussion, the scientific literature is really limited. It's very hard to study brain injury, very hard to study concussion. Recruitment is difficult. Following the patients is difficult. But the evidence favors the use of our friends, the SSRIs. What are the general strategies? The ones that I use and the literature supports. We use the least invasive option. We start very low, ridiculously low. My colleagues in general psychiatry laugh at me when I tell them how low I start the patients, and we very slowly, safety permitting, increase the dose. Side effects tend to be more common in patients with concussions and more troublesome in traumatic brain injury. So that's why we go low and slow. And there is a lag time of 4 to 6 weeks before the patient feels any improvement. Wait, what? Yes, 4 to 6 weeks before we see anything. So the patient goes through side effects initially, keeps on taking the medication. I keep on hearing it week after week. I'm not better, I'm not better, I'm not better. And I have to sound like a broken record. You're gonna get better, you're gonna get better. It's a mistake to, especially in brain injury, to rush and increase the dose prematurely because you might be overdosing the patient. The number of milligrams necessary might not be as high as one thinks. First line, the SSRIs. These two agents, sertraline and citalopram, I'm in yellow because these are the only two so far that have a level of relatively good evidence in brain injury. Doesn't mean that the others do not work, but these are the ones that have the best evidence so far. Second line, venlafaxine, and I tend to use these three quite a lot. Third line, nortriptyline and amitriptyline. Our colleagues in other areas like neurology and physical medicine and rehabilitation use amitriptyline or tryptyline quite a lot and quite correctly for the treatment of chronic pain syndromes like neuropathic pain or migraines. And there's nothing wrong with that. And oftentimes we combine them in a cautious way to obtain a better result. In some cases, we need to use stimulants to augment the results like methylphenidate. Less than ideal, Wellbutrin or bupropion, because it has a bit of a tendency, very small percentage of seizures in patients who are prone to them. And definitely no MAOI inhibitors, because if a patient with memory impairment, attention, concentration challenges is taking these medications, but forget that they cannot eat aged cheese or certain foods with a substance called tyramine, like red wine, they might end up being in deep trouble. So I don't touch them. Rate of response. Not every patient will respond to the first antidepressant. The rates varied, and we don't know in brain injury, but it's about 70% of patients respond to the first one. Some say less, but a common issue in these studies is that the patients were underdosed. Occasionally, in severe cases or with sluggish response, we have to use more than one antidepressant, which is called an augmentation strategy. Now remember, beware of Dr. Google. The response of your best friends forever, second cousin neighbor, does not predict yours. If you go online, you're going to find equal number of people complaining of side effects that were horrible, from I grew up a horn to my sex drive was horrendous, to patients that respond very well. But the people that post the most tend to be people who had a problem, and rightly so. And so there's a bit of a skew there. There's also commercial interest involved, so it's not a reliable information. Talk to your healthcare provider first. As I said before, family history of response and personal history of previous response predict yours. A minority of patients will not respond to medications. That's what we call treatment-resistant depression, in which case we tend to use other strategies, which is beyond the purpose of this talk. So what are the side effects? In this, I love this particular graph. In these bubbles, the larger the bubble, the more likely the side effects. So right away, sexual problems, which means low libido, low sex drive, which could create impotence, not because it affects the penis, because the drive is low, no drive, no response. Topic for another occasion. Very common delay in ejaculation, which for some patients with a premature ejaculation is actually good. In the female, again, delay in reaching orgasm or low libido. And these are usually bothersome for patients. Weight changes could be up, could be down. And this one is the one that drives me crazy. Because some patients will put on 10 pounds on sertraline, and another patient, same age, same gender, might lose 5 pounds on sertraline. It's unpredictable, hard to tell. Sometimes we switch agents and some patients respond better to others when it comes to this. Headaches, Gastrointestinal symptoms like nausea and loose stools or constipation tend to go away. Fatigue is common, not so much with certain medications like the SSRIs, but it's relatively easy to manage by switching the medication to nighttime. Sleep changes, either too much or little sleep. This particular one tends to be a bit of a game changer. So if the patient develops insomnia, really bad insomnia, chances are that's not the right medication, and switching it to morning might not work. Dizziness is very uncommon. Heart rhythm change is extremely rare. Coagulation challenges. Serotonin inhibitor drugs tend to also make platelets, which are tiny pieces of cells that clump together in our blood and form a clot, inhibits their clumping because platelets also have serotonin receptors in the surface. So there's a very small risk of bruising or bleeding, especially if the patient has a tendency towards bleeding or is on anticoagulants. Although, in all honesty, I'm yet to see a serious anticoagulation side effect just from this issue. And lastly, extremely rare, I wanted to make an even smaller bubble, but you couldn't see it. Serotonin syndrome, which can be a dangerous, but extremely rare, like 1 in a million syndrome where there's hyperactivity of serotonin. I don't have enough time to explain more about it. So we go back to symptom, continue with worry, anxiety, etc. And let's focus a bit on sleep disturbance. Sleep disruption in mild traumatic brain injury, it is very common and very complicated issue. Virtually every single patient I see in my clinic, because of concussion, post-concussive syndromes, or severe brain injury, has a sleep disorder or a sleep problem. It tends to be multifactorial, many causes. I have to tease out one by one. The most common form is insomnia, which is difficulty initiating or maintaining sleep, but can also have hypersomnia, the opposite, sleeping all the time, or parasomnias. Parasomnias are abnormalities in sleep, like nightmares or abnormal movements during sleep, or sleepwalking, sleep talking, etc. There might be a history of pre-existing sleep problems, or other problems like pre-existing anxiety and mood problems, sleep apnea, respiratory, very common and underdiagnosed, pain problems, neurological issues like cramps, paralysis, pain, neuropathic pain, or environmental issues. The partner snores like a locomotive, or they live in a very noisy environment. It's too warm, too hot, too cold, etc. What about sleep medications in traumatic brain injury? The sleep medications are a complicated, careless bunch like this guy. Benzodiazepines, the PAM family, and I'm not talking PAM the spray, lorazepam, diazepam, clonazepam, the Z family, zopiclone or Imovane, zaleplone, zolpidem. Tricyclics, like we saw, one of the side effects of amitriptyline, I forgot to put imipramine there, nortriptyline and doxepine, is sedation. Patients feel very tired. So that's also a possibility to use in sleep. And antidepressants like trazodone and mirtazapine. In extreme cases, although I've seen some general practitioners and psychiatrists prescribe antipsychotics for severe cases, in non-brain injury cases, I'm not happy using them. And over-the-counter medications, sleep aids, you name it, are basically antihistamines which have a side effect of sedation, and they're marketed as sleep medication when in fact it's just an antihistamine. So which ones are problematic? The red ones, the very subtle retina breaking red color font, lorazepam, diazepam, clonazepam, and the Zs. There's research, now about 10 years old research, associating, not demonstrating causality, but associating the use of these agents with dementia in chronic use. Amitriptyline, nortriptyline, and doxepine can be used, provided they are carefully monitored and the patient tolerates them. Trazodone and mirtazapine, in my practice, are the go-to. Quetiapine olanzapine, aripiprazole, which are antipsychotics, I don't use. And I definitely ask patients to stay away from over the counter. So which one is the best? The Oscar for the best sleep medication goes to, drum roll, absolutely none. There's no single medication that is the best for sleep. They are marketing now a new family of sleep medications that are melatonin enhancing agents. Just like the serotonin enhancing activity agents, the new family is melatonin based. We still don't know what they do in brain injury. It's too new. So sleep disruption, treatment needs to target the underlying cause. This is the most important thing. The vast majority of patients with traumatic brain injuries have an underlying cause for their insomnia. Examples, as I said, sleep apnea. With a CPAP mask, the sleep apnea goes away, the sleep improves. If the patient is in severe pain and cannot sleep because of that, analgesics. This is fantastic, but it takes the patient's work, and sometimes patients are a bit reluctant to engage in cognitive behavioral therapy for insomnia. Do yourself a favor, Google CBTI. There are many sites. Some of them are free. Some charge you a very small fee, and they teach you how to develop skills to sleep better without the need for medication. Exercise, underrated, underdiagnosed, undervalued, incredibly effective. Structure bedtimes and awake times, no naps. We call this sleep hygiene. Go to bed at the same time, wake up at the same time, no matter what time you went to bed and how many hours you slept, and do not nap. Avoid sleep disrupting substances like alcohol, caffeine, recreational drugs, tobacco, and the latest addiction, screens. Did I mention exercise? And limit liquids 3 hours before bed. Did I mention exercise? Hold on, let's sleep on it. If there's a need to use medications, the least complex and benign medications in the context of mild TBI, as I said, would be trazodone, starting at a really low dose, like a quarter tablet, 12.5 milligrams of a 50 milligram tablet, and gradually increase it, or mirtazapine starting at 7.5. Mirtazapine tends to provoke weight gain, and sometimes patients gain a lot of weight and don't like that. So God as a chicken, God as a kid tries to make a chicken in his room. I really miss Gary Larson's The Far Side. And like this cartoon shows, in my field, since we don't have the ability of go and take a piece of the brain and look at it in the microscope and then returning to the patient, is a matter of a trial and error approach. We have to be patient as clinicians. The patients have to be patient with us. Communication is the key. We need to explain how the lag time is, how the medications act, what are the goals, what is realistic, what is not, to engage the patient as a partner rather than just a top-down approach. And with that, I will thank you for your attention.
There we go. Thank you very much, Dr. Snaiderman, for that excellent talk. So for everyone watching, you can now, I see a few questions coming in. So if you do have questions, please just put those into the Q&A box. We have a first question. Does anything work better for constant dizziness? So I'm not sure if this is referring to, I guess, maybe someone who has some mental health challenges and also has dizziness.
Hard to tell.
Yeah.
My approach is to basically treat the symptom as non-psychiatric first, as I said. So if the patient is presented with dizziness, I want an ENT consultation or a dizziness clinic, a neurologist, a physiatrist. I want to see what is happening other than just a quote mental health issue. So I'm not the right guy to talk about chronic dizziness. Apologies.
Mm-hmm. And Sandy, I would just add that we have done full sessions on dizziness, and so you can look to the Canadian Concussion Center website and go back and actually hear experts in that area speaking to that issue. Our next question, I believe, is from perhaps Dr. Tardif. What about I'm not sure if I'm going to get this out, lemborexant for sleep?
That is one of the ones I was telling you about, the melatonin receptors. I don't have experience with them. I have a couple of patients who were prescribed lemborexant by sleep disorders specialists and have had good result. One so-so, the other one is loving it, having a good response to it. Hypothetically, it makes sense if you foster more activity of melatonin in the pineal gland, going through all of the arousal centers in the brainstem, the reticular activating system. Makes sense that it would work. The jury is still out when it comes of brain injury. I cannot comment.
Okay,
Hi,
great.
Gaetan, by the way.
Thank you. Lori is asking, do you have any opinion on medically monitored cannabis use for sleep with CBD and THC combination?
Oh, do I ever have an opinion? When do I not have an opinion about cannabis? Not what you want to hear, perhaps, Lori. Not yet ready for prime time. There's been a huge influx of cannabis requests in our practices since it was legalized. It was always there, but it was not legal. Patients were using it, but it was not legal. I've been doing this for a long time, and I've never seen a patient with a concussion that benefits in the long run from cannabis. There's side effects in attention, concentration, motivation, especially motivation, hence cognitive skills. And it's hard to treat somebody with depression if they're using cannabis. Now, is it dose specific? I don't know. There's more than 130 compounds in cannabis, and we know two. We know CBD and THC. The others are being studied, but we have no clue what they do to the brain. And that's scientific grade cannabis. When it comes to commercially available cannabis, especially if it's not sanctioned by an establishment, if it's street cannabis, who knows what's there? We have no clue if there's pesticides or is there all the toxins. We have no clue. I don't say this from a moralistic, paternalistic point of view. I say this from a pure neurochemical, excuse me, point of view. I've not seen good effects. If you had terminal multiple sclerosis or ALS or cancer, and we don't care about your cognitive status, and we don't care whether you're going to be able to function and go to work and participate in things, that's a different story.
Mm-hmm.
So
Okay.
when it comes to cannabis, clinical judgment is very important. I tend not to prescribe it, but I don't deal with severe intractable chronic pain patients. So I do have patients that come with it because of intractable pain and benefits from it, but I warn them, it's going to be tough stabilizing mood if you're using cannabis. Then we have to separate, is this cannabis dependence, cannabis use disorder, or occasional use of cannabis? And that's beyond this talk, but told you I have an opinion.
Mm-hmm. Thank you. And just to quickly follow up on that, Kyle was kind of asking the same question, but he is asking like CBD. So do you have anything if it's just CBD oil, for example?
I have bad news for you. I don't have the actual reference, but I read somewhere that when Health Canada did a analysis of random samples of CBD oil, pure CBD oil, THC was present.
Hmm.
So I cannot answer the question. There's
Okay.
when it says pure CBD, I really doubt it.
Okay. All right. Thank you. Amanda is asking, is there any evidence of gabapentin treating the symptoms of concussion or persisting concussion syndrome?
Gabapentin is used. First of all, gabapentin started life in the early 90s or late 80s as an anticonvulsant. It's a seizure disorder. It's a seizure medication. Over time, it became more a treatment of neuropathic pain or pain that is produced due to nerve damage, not necessarily other causes. The evidence, and I'm definitely not a pain disorder specialist, and Dr. Tardif would have way better experience than I would when it comes to treatment of neuropathic pain. But when it comes to concussions, widely used for the treatment of headache prevention, headache treatment, migraines, widely used in treatment of MSK pain following a whiplash, etc. It has very weak anti-anxiety properties. We don't know if it's because it is sedating or it actually has effects on the anxiety circuitry. Most anticonvulsants, if you think of them, act as a light dimmer. So those switches where you dim the lights with a slider or a knob, that's how they work. They lower the intensity of transmission in the neurons to reduce the electrical activity and prevent seizures. Not all, but some. Gabapentin is one of these, without getting into the details. Has it been used for the treatment of anxiety and depression? Off-label, I wouldn't necessarily use it because there are better medications. I've seen one or two cases over the years that responded to a combination of an antidepressant and gabapentin, and we questioned whether we were really treating insomnia with the gabapentin, and that's why the patient got better.
Okay. And I think that answers Caitlin's problem about gabapentin and sleep. Sucheta says, thanks for an excellent presentation. I'm wondering if any of these sleep or mood medications would impact teens or adolescents differently than they would for adults.
Hi, Sucheta. Thank you for the question. All antidepressants, and I'm not a child psychiatrist, I put it out front, and I don't treat patients under the age of 18, but all what we call psychotropics, all medications that enter the brain, which is a psychotropic and affect mental health function or brain function, all of them have to be carefully used in kids and teenagers, but they are used. So they are safe. They have to be monitored carefully. Years back, I always say 10 years, and it's probably more than that. Years back, there was a very alarmist paper that stated that using antidepressants, particularly SSRIs, in teenagers produced increase in suicidal thoughts and suicide. Later on, this was studied to death, as you can imagine. Everybody panicked, and very qualified people with much higher IQs than mine researched the topic, and it was proven to be a false association. However, the government in the States, the FDA, forced the pharmaceutical companies to put a warning. And when they did that, Health Canada did the same for use in adolescents. Now, let me give you an example. Say you have a horrendous migraine, right? And you take Tylenol. And you take the Tylenol and 10 minutes go by and the migraine gets worse. It's common to think, well, Tylenol gave me a worse migraine, when in fact, Tylenol hasn't yet worked. So what happens in depression, if you give the patient a medication that's going to take 4 to 6 weeks to start working, and in the meantime, the depression might be getting worse. So you haven't caught up with the depression, you haven't caught up with the anxiety. And we know that about 11% of patients or higher with depression experience serious suicidal thoughts. So hard to tell, was it the medication that caused the suicidal thoughts, or was it the illness progressing before the cavalry came to the rescue, so to speak? The research has been clear. My colleagues in child psychiatry prescribe antidepressants without any problems. They have to monitor the patients just like we would monitor any patient with depression, whether it has a brain injury or not. That was a long answer for a question, Sucheta. I hope I answered it.
Thank you. Lori's just asking memantine for depression, question mark.
I don't know. Memantine is a medication used for the treatment of symptoms of cognitive decline in Alzheimer's. I'm not familiar. In dementia, it can be used for behavioral issues in dementia. I am not familiar of the use of memantine in brain injury. So I cannot
Okay.
answer your question. It's the freedom of saying I don't know.
Okay. Chris is asking, speaking of options, what about just simple melatonin supplements for sleep? Are they an okay idea, bad idea, dose?
This is a very, very common question. I've asked two of my sleep disorders specialist friends, and they laugh at me when talking about melatonin, because they tell me that melatonin has a 1.5 hour half-life, which means that by the time in 1.5 hours, half of the dose of melatonin has been destroyed. So the full life is about 3 hours. And yet I see patients that respond to it. Whether this is an actual effect of melatonin or the very strong and valid placebo effect, we don't know. Some of our physicians prescribe melatonin, and when I say, well, is it really working, they swear by it.
Mm-hmm.
If the patient thinks that they're going to help, they likely will help. And if it goes on helping for more than, say, a month, chances are that's not just placebo effect. Chances are there's some effect. There's been question as to whether melatonin survives the gastric acid, whether melatonin can be absorbed. There's been scares in the 80s and 90s about melatonin coming from the pineal glands of cows at a time when we had mad cow disease. Currently, melatonin is completely synthetic, not animal sourced, as far as I know. If the patient tells me I've been taking melatonin, it's working, fine. One exception. If you have a disorder called REM sleep behavioral disorder, melatonin is a proven treatment, but at very high doses. So if you have a disorder in which you're acting out your dreams and literally punching, and sometimes the poor sleep partner gets punched, or acting out the dreams and walking and have no memory about it, that's called rapid eye movement, which is dream sleep behavioral disruption. And melatonin is a treatment.
Okay, great. Thank you. Vicky is asking about what do you think about drugs like Adderall to help with things like motivation, ADHD? What antidepressant would you recommend to take with it?
I don't particularly prescribe Adderall because, and I keep on going to back, and please don't think that this is just an alibi to get out of the question. It's reality. In brain injury, we're flying by instruments because it's so hard to study. Very hard to get 1,000 patients with brain injury do atomoxetine or Adderall and have placebo. Very, very hard to do. So I only use the agents for which we have some level of evidence in brain injury. I'm not familiar with Adderall as evidence of brain injury. My first approach would be to treat with something called modafinil or Ritalin, methylphenidate, for which there is evidence. We know the interactions, we know the side effects, we know the half-life, how long do they last. There's a lot of people on it, so I feel comfortable first prescribing those. My next would be lisdexamfetamine, which is, as an amphetamine, I'm not too keen on prescribing. So the typical case would be somebody with attention deficit and hyperactivity disorder, which because of the ADHD, and we know that patients with ADHD are more prone to be impulsive and get head injuries, comes already on a medication for ADHD and is now depressed and has all sorts of cognitive problems. I have no problem putting them on an antidepressant, but I don't particularly prescribe Adderall. Perhaps my colleagues that deal with ADHD feel, not perhaps, I'm sure they feel way more comfortable, but in the brain injury literature, I don't have yet enough data to feel comfortable prescribing it. My first rule is do no harm. So unless we have
Okay.
the data, I don't prescribe it.
Okay, great. I'm just going to quickly go back that you were speaking on gabapentin, and Caitlin just wanted clarification about its use in sleep disorder. So just wondering about gabapentin and sleep.
I'm not familiar of I'm not familiar in terms of gabapentin being a primary medication for a sleep disorder. It can be used for insomnia just because it's sedating. One of the side effects is that it's sedating. And in menopause, for example, some of my colleagues prescribe gabapentin starting at 100 and going to 300 milligrams for menopause-related insomnia, which can be hard to treat, and with good results. So in my field, in brain injury, I don't prescribe it as a sleep medication.
Okay, great. Thank you. Lori's asking, do you have any understanding of functional neurological disorder from a concussion with PCS, post-concussive symptoms, and what can you use for medication treatment of depression, anxiety, and insomnia, I guess, in those cases?
That's a whole new presentation. How long do you have? Functional neurological disorder used to be called conversion disorder, which was a no-known name these days. We used to think that conversion disorder was in people who were converting emotional stress, anxiety into physical symptoms. There's been a lot of research on functional neurological disorder showing that it is actually a neurological problem. It is actually a functional problem, a function of the brain. We don't see yet the anatomy of the disorder, like if it was a stroke or a tumor, and that's why the name functional. The moment we see, oh, there's the lesion, it's a structural issue, an anatomical issue. We don't have the imaging yet with a resolution high enough for us to see there's a problem. We're starting to see spectroscopy in which we analyze what chemicals are produced after an injury, and we can measure them with very sophisticated strategies. So it is a rare illness. It can present in a variety of shapes and forms. Sometimes post-concussive syndromes are actually functional neurological disorders. We just happen to have a mild head injury, and then the functional neurological disorder either comes to the surface or reactivates. Response, they can respond to antidepressants because of the anxiety they produce. They respond to cognitive behavioral therapy, but it's a long process.
Okay, thank you very much. I'm just aware of the time, but I'll try and squeeze in another one or two. Alexander is wondering about, so if there are symptoms of low energy and fatigue and cognitive processing trouble, can you give some guidance for medications that might help with those symptoms?
Whenever I see somebody with cognitive processing issues, particularly speed issues, the first thing I ask is about, is there something else happening here? How old is the patient? If it's somebody age 19 with processing speed issues, I get a bit alarmed. If it's somebody my age, and I'm not telling you how old I am, and there's a bit of slowing down of process, I wouldn't go to jeopardy. I wouldn't be as concerned. So number one. Number two, what are we talking about of speed process slowing down? How bad is it? Is the patient sleeping well? What other medications is the patient taking? Is there alcohol, cannabis, or other substance use related? Are there any other symptoms associated with slowing of the process? Peripheral neurological symptoms. Are there any other things that could be making the brain slower? If this is an elderly patient, Is this something to do with dementia perhaps settling in, or a medication for another condition, a painkiller that's producing this? Are there medications? Yes, there are medications, but before I prescribe a medication, I want to make sure that all of these questions are solved. Sometimes the patient has depression, and one of the hallmarks of depression is slow process of thinking, what we call bradiphrenia. So the patient is almost thinking through, like walking through molasses, and that's depression. You treat the depression, that improves. A sleep disorder might do the same.
Great, thank you very much. Okay, well, I think we're going to have to cut it off there. Thank you so much, Dr. Snaiderman, for an excellent talk and for answering all of the questions.
Before I say goodbye, and can I interrupt for a second? We presenters live and die by the power of your evaluations. Please take a minute, skewered me, criticize my idea, doesn't matter, but please fill the darn evaluation.
Yeah, and it's very quick. It will take you less than 2
Very quick.
minutes. So it will come via email. So we really do welcome your feedback and suggestions. Just to let you know, we will be back in 2 weeks, and we will have Dr. Paul Rinaldi with us, who's going to be talking about vision therapy and vision specialists. So thanks again, and have a great evening, everyone.
Thank
Take
you.
care.
Thank you for the invitation.